pick up from investigations. We're going to look at labs that are necessary for this patient coming to the OR. We'll need a complete blood count, and this is where we'll be so much interested in looking at the white blood cells, looking for leukocytosis, and thrombocytopenia is usually considered as a poor prognosis sign, if at all present. So we have to check what are the thrombocyte levels. Other investigation required is inflammatory markers. From the pathophysiology of COVID-19 usually triggers massive inflammatory reaction. So we look at those inflammatory markers. D-dimer and other cardiac markers are usually associated with increased mortality because of heart injury to the heart. BMP, which is basal metabolic panel, is recommended, and especially in renal failure. BMP basically entails checking of urea electrolytes, potassium, sodium, to be specific. And in the setting of renal failure, we have to know what are the creatinine levels, because if you look at the pathophysiology of COVID-19, the major organs affected usually the heart, the lungs, and the kidneys. Pre-op assessment for these children we do as regular for any as any other surgery. So airway assessment, NPO status, and all others is recommended. Specific for impending elective surgery. So depending on the kind of elective surgery that is going to happen, then specific preoperative assessment is usually indicated in that particular scenario. So radiology, chest X-ray is usually very much necessary, and literatures tell us that in early stages of COVID-19, X-ray may not be recommended, but at late stages, mostly the injuries to the chest usually much visible 10 to 12 days after onset of symptoms. So if you look at this X-ray that we have, it's very typical of COVID-19. COVID-19 pneumonia, usually there is infiltration and opacity of the lungs. And it gets worse if you look at the last X-ray, in which there's a lot of infiltration of both lungs, showing severe pneumonia and respiratory distress syndrome. Induction in pediatric COVID-19 patients. Anxiety, very common in children, so premedication is indicated, usually to stop crying and resulting in viral isolation. So precautions usually necessary to prevent that. So avoid nasal premedication since it can cause aerosolization. Improvise clear barrier, including face shield between patient and anesthesia provider, may also decrease virus transmission. When checking for the leak, the anesthetist should not place their face close to the patient. This is just obvious to avoid or reduce the risk of transmission. Consider closed suction to avoid isolation, and that is what was recommended. Closed suction to avoid exposure of virus to the environment that can infect the providers. Then protect the anesthesia machine with viral filters. Place it on the patient side of the Y-piece. The viral filters should be used for transport of intubated patient. We cannot stress on the use of viral filters. It's been emphasized on a lot. So COVID-19 intubation tray, this is just basically some of the requirement that we may need, that we will need in order to manage these patients' airway effectively. If you look at it, we'll need Macintosh, video laryngoscope blade, SGA, which is the supraglottic airway devices such as LMA, endotracheal tube, of course, different sizes, bougie and stylet, and of course, endotracheal ET CO2 monitor. We'll also need an AG tube in order to decompress the stomach if necessary, and these other airway adjuncts like OPA, that is oropharyngeal airway, and nasopharyngeal airway. And then the last point there, inline suction. Inline suction is usually very much necessary and very much indicated for this particular patient for the obvious reasons that we've said. And then the closed circuit is usually recommended, obviously to reduce aerosolization, just to make sure everything is inside the circuit, and reducing much exposure to the virus, much exposure of the virus as much as possible. So airway management, this is a very busy slide here, but look at the ones highlighted in white. Full PPE is very much recommended with N95, with use also face shields unavoidable. And the most experienced member is the one usually allowed to intubate. Hemodynamic evaluation and optimization of the patient if needed. Use of bacterial filter has also been repeated there. Use of closed system suctioning is recommended. Pre-oxygenating the patient with 100% and RSI for inducing this patient is highly recommended by most literatures. We are asked to limit bag mask ventilation unless really necessary. Frequent pressure only in case of ongoing regurgitation. So use of video laryngoscope with separate screen if available. In an anticipated difficult airway, anesthetist may be called to intubate the patient. The last part that I can talk about is use of end-tidal CO2 monitor and chest X-ray to confirm correct positioning of the endotracheal tube. After intubation, appropriate cleaning and disinfection of equipment and environment is usually mandatory, just to prevent the risk of exposure. So this slide has 3 parts. It's one of the checklists that's used by developed one of the hospitals, which we can easily adopt. So we can pick some few things here that we can learn from. The first part is pre-intubation. Basically, that's comprising of preparation that is necessary. If you remember the 10 golden rules of anesthesia, you must prepare for the difficult airway. Hence, you can see a bougie, stylet, LMA, check the laryngoscope, make sure the suction is working, adequately position the patient, make sure you have a working IV access. Your drugs will be ready and ready to go. Make sure you have an assistant who can also intubate in case you fail to intubate this patient. And then the second part for the intubation part of it, we said that rapid sequence induction and intubation is very much advocated for by most literature. Therefore, pre-oxygenate this patient for about 3 to 5 minutes, just to make sure that they build up enough FiO2 and increase their FRCs to reduce desaturation during intubation. Give drugs and avoid backing if possible, just to reduce aerosolization. So that is plan A. Plan B, if in case plan A fails, then you go to plan B. And just the last part of plan A, consider use of video laryngoscope. That's just to enhance your chances of intubating this patient. But in case you fail in plan A, you've tried and you failed to intubate this patient, then you activate plan B, which is not very much recommended, but in event you are there, then use of supraglottic airway like LMA is advocated for, so that you restabilize the patient, get the saturation up before you revert back to plan A. But this usually this increases your chances of increasing hospitalization, because you will be forced to bag mask this patient. And if plan B failed, then plan D comes in, which of course we know involves surgical intervention. So needle glucothyrotomy, and of course, having an emergency tracheostomy. But the literatures advocate for plan A. Make sure plan A succeeds so that you don't go to plan B. That's why adequate preparation is advocated for. Make sure you have the most experienced person who can intubate this patient. All this is intended to increase the chances of successfully intubating this patient. So post-intubation, there are various things they are advocated for. Make sure you attach bacterial filter, check oxygen tube 100% FiO2, and then positioning the patient just before the surgery begins. So once intubation has been done and we go into intraoperative management, adequate positioning of this patient. In COVID-19, most of the patients managed in the ICU, they advocate for prone positioning. The reason why they advocate for prone positioning is because it maximizes on lung expansion and enhances oxygenation of this patient. So in theater, we may also advocate for this positioning, but of course that will depend on the type of surgery. If the type of surgery cannot allow prone positioning, then this positioning will be very much difficult. Therefore, you'll have no choice but to optimize oxygenation of this patient by playing around with their ventilator settings, that is the rate, PEEP, and FiO2. So increase the FiO2 up, increase the PEEP if necessary, especially in the setting of acute respiratory distress syndrome. They will require higher PEEP in order to oxygenate them. And we may also increase the rate or decrease the rate as necessary, depending on how the patient is saturating. But remember, increasing the rate or further decreasing so much will also affect your metabolic factors. So vent setting is very much important, and that can be customized as to the patient we have on the table. Closed circuit, we repeated that several times, so we have to use that. Use of muscle relaxant, no studies bars us from using this. So literatures actually advocate for use of muscle relaxation in order to reduce barking and coughing of this particular patient. Fluid management, this will be optimized to a particular patient that we are having, whether we give liberal fluid or control fluid. It depends on the patient that we have. In the setting of ARDS and pneumonia, probably control fluid administration will be advocated for. After the end of the surgery, we are encouraged to extubate this patient deep, if not contraindicated. The reason is to reduce barking and coughing and authorization, and in order to reduce transmission of the virus to the healthcare provider as much as possible. That will be the end of our presentation at that particular point. Hand over to Gatwiri, and we can accept questions at this particular point.
So thank you very much for that presentation. Despite the challenges, I think we've kept to time and we've managed to go through the presentation. For the nurses who are from Kenya who have joined us for this session, please take note of the CPD code that's on the screen right now. It's one that you can use to redeem for points for this particular meeting. So I'll go straight to the questions. We had received some on email, so I'll start with those ones. So these are questions from Miss Juliana, who asks, are there any special considerations when handling children with COVID-19? So I don't know if Macton wants to take up that question.
Yes, I can shed a little bit of light, then Dr. Kynes can come in. So special consideration in this particular patient with children with COVID-19. First of all, we have to know the pathogenesis or pathophysiology of COVID-19. It causes severe acute respiratory distress syndrome, which reduces the which causes VQ mismatch and causes desaturation and hypoxia in this particular, in all the patient and children included. Therefore, if we have to premedicate this patient because we said that that is necessary, then we have to give drugs that will not depress their respiratory system. You give a drug that depress their respiratory system, then you'll worsen the hypoxia. The next thing that I can talk about is COVID precaution is very much advocated for. Full PPEs with the F95 mask and shield is very much necessary. Another precaution that I can talk about is ventilator management. You have to maximize oxygenation of this patient. You play around with the three knob, PEEP, rate, and FiO2. So they require higher FiO2. You may increase the rate if necessary. You may give the PEEP if also really necessary in order to optimize oxygenation. Dr. Kynes can weigh in.
Thanks, Macton. I agree with you. I think all of those precautions that you mentioned now, as well as in the presentation, are important for managing any COVID-19 patient. And I wouldn't necessarily say that there are additional specific considerations in pediatric patients. Most of what we apply for adult management in terms of what you've mentioned in terms of induction, intubation, precautions for the anesthetist team will apply whether it's an adult or a pediatric patient. I do think something important to consider is whether the patient is symptomatic or not. That would certainly be a reason to delay or postpone surgery if at all possible. Actually, Mary Mangai mentioned a patient that she took care of, and she may want to jump in and describe their management, which I think illustrates that concept very well in terms of how you might approach postponing a surgery for a patient who has a diagnosis of COVID-19 to avoid possible respiratory complications or other issues that might come up after the operation.
Okay. Okay, thank you. Getuli?
So thank you for those responses. So I'll go to the Q&A section and we'll answer them in order of the way they came in. So Geoffrey Kitur asks, what's the best way of handling elective cases in relation to SARS-CoV-19? So I don't know if Jamal wants to take that question. Jamal, are you with us? So I'm not seeing him here. So maybe Macton, you can cover for him.
Yeah. So you just come up, come up again with the question.
It's regarding elective cases for COVID-19 patients. What is the best way forward?
Okay, elective. I think Dr. Kynes just answered that question on his last statement, that you have to select the patient who are either COVID positive or COVID negative. So the patients who are COVID positive, you further categorize them if they are having severe symptoms or mild symptoms, and then also the type of surgery that you want to do. So if the patient has severe symptoms of COVID-19 and the the surgery is elective that can wait, then I wouldn't think it is prudent to go ahead with the surgery. If the patient has mild symptoms that is not a danger to them, then yes, elective cases may go ahead or may not go ahead. But I think the main point is, what is the status of the patient in question? If they're having severe cases of severe symptoms, then elective surgery may be postponed in that regard.
I think if I can add to that, for the purpose of protecting the anesthesia and other providers taking care of patients, any patient with a positive COVID-19 test should be delayed, even if they're asymptomatic. Now, this depends on what the testing policy is at your facility. At our facility, we test every patient who is scheduled for surgery. And if that patient is positive and is having an elective surgery, then their operation is postponed, even if they have no symptoms. If their test is negative, then we can proceed. We often put in precautions, but we don't need the same level of precautions that we might use if the patient was known to be COVID positive, if they had symptoms, or if their status was unknown. If you don't have a universal testing policy in place, then you should be screening all of the patients, and anyone who has symptoms or is suspected of having symptoms or contacts with patients with COVID-19, they should be postponed. And you'll have to work closely with your institution to decide what to do with patients who have an unknown COVID status coming in for elective procedures. Some places have opted not to perform those. Places with adequate PPE are resuming elective operations with certain precautions in place for the anesthesia team especially. To reduce infections, things that you could do include minimizing the number of people in the room for any aerosolizing procedure, using N95, face shields, goggles, protecting your neck, and using other basic precautions like hand washing are also important considerations if you have a patient with an unknown COVID status. So I think that's an important caveat to point out.
Right.
Thank you. We'll move on to the next question. William asks, is it advisable to have an ICU in the institution before surgery? And I think this applies to COVID patients.
Jamal, would you like to respond to that? Unmute your mic, please.
Macton, I don't think Jamal is near his device.
Thank you, Macton.
Oh, he's there. So,
is it advisable to have an ICU in the institution before surgery? And this has been the question all around, and like practice around, and a number of hospitals that I have asked and consulted of. It's not a must to have an ICU before you go in, but again, like Macton has said and Dr. Kine said, depends with the severity of the patient. But the ideal state of affair, like it is you need to have a theater just specifically set for this patient, and you need to, as you set that theater, you need also to prepare for your PACU area or recovery area, ideally according to the severity of the state of the patient. So in my thinking, and most of the Kenyan hospitals I see around these sites, they don't do the COVID positive pediatric surgeries with that in mind. And I will say it is something to think of, is something to ensure that you have a safe landing from your anesthesia. I don't know if Martin has anything in addition to that.
I agree. ICU is a very sensitive matter in our country. Not so many hospitals have ICU beds, so it's a very gray area whether you should proceed or not. So I think before you begin the surgery, then you may need to anticipate the need for ICU before you decide whether you go ahead with that particular surgery or not. So just like we said, that if the patient has very severe symptoms and the elective surgery can wait, then it's prudent you wait and postpone that particular surgery. So I don't know if the question is in a case where you are done with the surgery, you did not anticipate this, but you now need ICU. Now, what do you do with this particular patient? Do you refer?
I think that's a difficult question, but I think in all cases use the best clinical judgment, and patient safety is of paramount importance. So as our chairman always tells us, don't be a hero. Do what is in the best interest of the patient. So if you need to refer, please refer. So I'll move on to the next question. George asks, why extubate deep as opposed to fully awake? Normally, no back-in if not extubated in second stage. So I don't know who'd like to answer that question.
Dr. Kites?
Sure. You know, this is a little bit controversial, but the thought process behind extubating deep is what you've mentioned, that a patient may have a smoother emergence without the endotracheal tube in place and be less likely to generate aerosols that could go into the room. Now, your point is great that as long as the airway is protected, ideally with a cuffed endotracheal tube in place, as long as that tube is in place, you're unlikely to be spreading aerosols into the room as long as the circuit is fully connected. However, if a patient's fully awake, coughing during the extubation, they may continue coughing as the endotracheal tube is removed, in which case they could spread aerosols through the room. So that's the idea. Now, there are many other factors that need to come into play. How stable is the patient? Do they have an aspiration risk? Will they be likely to maintain their airway after the endotracheal tube is removed while they're still deep? And those factors may influence you to wake them up, even given the slightly increased theoretical risk of spreading aerosols around the room. Regardless of whether it's deep or awake, everyone in the room caring for a patient who is known or suspected to have COVID-19 needs to have full protection in place to prevent spreading the infection. It's a good question.
Yeah, I totally agree with that.
So thank you for that. I'll move to a question that came in through the chat. It comes from Sue in Ghana. She asks, what type of induction are you using? Is it IV or inhalation? Most children don't want needles and will need to sleep by gas induction even before IV is secured. So what are your comments on that? Can I ask Dr. Kynes to answer that?
Sure. I think, you're talking about two different populations. If this is a patient who is not known to have COVID, and the community spread of COVID is low, then it's safe, likely, to proceed with an inhalation induction for those children. If there is a higher level of community spread, or the patient is suspected or known to have COVID-19, then I would advise doing an IV induction to avoid using positive pressure ventilation during an inhalation. That might be necessary during an inhalation induction. And that is assuming that the surgery is necessary to proceed and can't be delayed. That just helps protect everyone in the room from being exposed to the aerosolized virus during an operation like that. If the patient is symptomatic, then they absolutely should have an IV in place, because they will likely need treatment during the induction for complications that may arise. My limited experience caring for patients that are positive for COVID-19 has been that even if they don't have symptoms preoperatively, that they can have a higher risk of bronchospasm, which is not surprising given the respiratory infection. They may also have a higher risk of laryngospasm. And for both of those reasons, having an IV in place preoperatively would be much safer than proceeding without an IV for an inhalation induction for an operation like that.
So thank you for that response. I think we've gotten to most of the questions, and I know that there might be many more that we have not, but because of time, I think we will end there. Again, I'll give a few minutes for the Kenyans to take note of the CPD code, which expires on 30th of August. I want to thank everyone for joining us for this panel. For this webinar, we will be having them every Friday from 7 to 8 p.m. And we try as much as possible to keep to that 1 hour timeline. I want to thank the panelists. Jamal, from your background, we can see you're still at work. So thank you very much for making time to attend this session and give this talk. We appreciate the efforts. Macton, who's in darkness still, we also thank you for making time to attend this webinar. And Dr. Kynes, we cannot thank you enough. I don't know what time it is in the US. I'm sure it might be very, very early or very late. So thank you for making time to share your experience and knowledge with us. I think next week we shall be focusing on resuscitation of COVID-19 patients. So please be on the lookout for our emails and our social media posts about the same. If you have any questions regarding this and any other sessions we've had, my contacts are on the screen. And yes, I will give Dr. Kynes, do you have any last final words before we end this session?
Sure. Well, I do want to thank you again, Gitwiri, and the other panelists for inviting me to be a part of it. I always enjoy my time working with the nurse anesthetists there in Kenya, and look forward to being back again in person sometime soon. When it comes to pediatrics and COVID-19, I do think there are some other issues to be aware of. There are indirect effects when it comes to how children will fare during this pandemic. They do need our attention and care for a lot of reasons. I also want to commend all of you for the work that you are doing. You are obviously at the front lines in more ways than one, and the commitment that you have to your patients and to your communities is very admirable. And I want to commend you for the work that you are doing and continue to do for the patients that you're taking care of each day.
Thank you for those kind words. I don't know if Macton, any last comments?
Yeah. Thank you, Dr. Kynes, and thank you everyone for joining us. I hope we've learned something, and let us continue the good work. Otherwise, nothing much from my side. Thank you very much. Have a good night.
Thank you. Jamal, any last word?
Thank you, Gatwiri, and thank you, Dr. Kine, and all of us, Martin, for this so much informative session. We keep on learning every day, and we just want to pray that even we are growing more and more in knowledge through these sessions. And thank you, everyone, for the questions and participation. Thanks, Gatwiri.
So thank you again for making time to join us for this session. Please, as always, when you get this notification for our session, please share them with your network. We will appreciate your feedback, both positive and negative. So feel free to give your critique, what we have done well and what we could do better, because we are all in this to learn and grow together. So keep safe and have a great weekend. Thank you.
Bye-bye, everyone.
Bye-bye.
Bye, guys.